I had started working at the UMC 10 years ago and started working with signal detection. Prior to that, I worked at a pharmaceutical company with clinical trials, and prior to that, I worked clinically as a nurse in Sweden and in America. I'm very happy to be here, and I will this session will be a little bit different from the sessions you've had this morning, focusing on different methods within pharmacovigilance. This session is more leading you over to the afternoon sessions, where you will talk about specific groups, subgroups within pharmacovigilance, and this is the subgroup of children. And I'm hoping to make you aware of the specifics within pediatrics and pharmacological treatment with this session. So I will first give you a rough background to the specifics and the uniqueness of treating children with medicines, and also give you some results from a study that we've done at the UMC in preparation of actually focusing on signal detection in the subgroup of children. So that's the scope. And you're very welcome to interrupt whenever you would like to. So if you've been on this course now for maybe 2 weeks, and some of you first day today, and I think most of you are aware of that medicines can cause patient harm resulting from the pharmacological effect or individual patient idiosyncrasies, or also medication practice and use. And why I'm showing you this slide is because the latter point is very important within pediatrics. And I hope you will understand why when I go through this presentation. In clinical trials, you start to test the candidate drug on animals, but you often don't test it on premature or newborn animals. You continue and you study the drug on healthy volunteers, and then you study it on patients. But in those randomized clinical studies, you often exclude children and elderly. So you have the clinical trials are very homogeneous in their population. It's restricted in time. It's restricted in the level of disease severity, for example. And if the children, for example, are excluded, then we have a limited information on dosing, warnings, precaution, and adverse drug reactions specifically for that population in the product information. So there's a lack of information for the pediatric population for some drugs because they haven't been tested specifically on children. So that leads to extra consideration when medicines are used in children. Another complication when it comes to children is that they are different from adults, we know that, but they're also very different within themselves. You have a little toddler and you compare it to a teenager. And you also have the very newborn who's almost a part of the mother. So it's a complex group of patients within themselves. They differ biologically and they differ psychosocially. So that's good to have in mind when you think of children and pharmacology. So especially before the age of 2, they differ markedly when it comes to the gastrointestinal tract, the skin, muscle, and liver the renal organs. So that's very important to keep in mind. The medicine will be taken up differently, will be distributed differently. The fat-water content ratio is different. The metabolism will be different, and excretion will also differ, especially for the ones before 2 years old. When it comes to teenagers, the hormone activity influences. They've noted it's indicated that the hormone activity actually is correlated with the level of enzyme activity from the liver. So if you're interested to read more about that, I very strongly recommend the 2 references given in this presentation. The children also differ psychosocially. They go from total dependence to independence. They have a limited way of communicating when they're very small, and ability is quite adequate when they're teenagers and full grown. But this influences monitoring, especially the communication skills. I mean, to monitor for ADRs is very different for these small ones who can't communicate and describe where their discomforts. And especially the biologically different children, that influences dosing and also administration of medicines. So the whole scenario is very complicated when it comes to pediatrics. And it's good to keep in mind when you get reports for children. It's or when you evaluate child patient records that were given today, because the background leads to that calculation is needed for the dose for each individual child. And often, for the very small ones, dilution is necessary of infusions, for example, or other medicines that actually have been developed for adults. And you're stuck with giving very, very small amounts of medicines, and you have how much do they actually get from those small amounts? And you have a need for extemporaneous preparations. Another consideration is that children, I mean, most of the time they have their whole life in front of them. And so they have a different risk-benefit. They could have a different risk-benefit profile, and that's good to have in mind. And also, drug therapy during childhood might actually affect, or problems might be detected later on in life. That could have a correlation with a drug, but that's really, really difficult to detect. So that's a challenge. An example on the long-term effect is and this is a little controversial. It's the glucocorticosteroid drugs, asthma treatment for children, and its effects on growth, potential effect on growth. Another situation is because the drug has not been tested in children, or this is not always the case, but it is the case quite often. Then you will have off-label use. Physicians prescribe the drug. Of course, they need to prescribe the drug. You can't keep drugs away from children. And in a review article, recent review, looking at studies and off-label use, which is defined by not supported by product description, they saw that 18 to 65% in hospitals were prescribed drugs that were off-label. They were not and 11 to 31% in outpatient care. So it's always a little less there. Another specific for the children, when a drug has been developed for adults, for example tablets, then they're not always suitable to give to a child. So there is a lack of 8 suitable dosage forms. But even if a drug is labeled or has a recommendation to be used in children, a group of researchers saw that up to 25% of medications indicated for children actually lacked appropriate dosage form. And I have an interesting example of this. I know you can't see this, but it's the summary of product characteristics for captopril. And it says that, oops, let's see if I can do this. Now you know what's going to come. It says that for children here, it says the efficacy and safety of captopril have not fully been established, but there are actually dose recommendations. So you have the initial starting dose is 0.3 milligram per kilogram, premature even less. So what are you actually going to do if you're going to get if you think of a newborn, 3 kilos, 0.45 milligram, and you have a tablet of 12.5 milligram. So I think this was probably one of the examples that this research group, but it's better than nothing, because captopril is used for little newborns and with heart problems, and but you certainly need we need you pharmacists to help us to prepare this drug in a correct way before it's given to the child. Do you have any questions? I feel like I'm talking all the time. Yeah, good.
I was thinking about that. Even worse than that is when you have a newborn with a very low weight.
Yes.
So before that, you have a renal or mature renal. So you don't know. Nobody's know how the medication is going to work.
Yeah. And you're in, and I think that's why monitoring the effect and the adverse effects when giving these children the drug is utterly important. And I think I would promote an international work around this, because it's so rare that you give drugs to these premature, really early, unless you're in the US, you have a greater population, but the rest of us often have small populations. Like in Sweden, we have 9 million people and a few children's hospitals dealing with these children. And even within Sweden, the hospitals don't communicate. They outline their own guidelines for specific drugs, but it's the communication between the hospitals, even within Sweden, is poor. But we're working on it actually here, on a national collaboration of better use of medicines for children.
Yeah, we also have it in our hospital in Tenerife with vancomycin, for example.
Exactly. That's a problem drug. Absolutely. Anyone else would like? You're hungry. I just continue. Another situation is that they have seen is that medication error. In a study in the US, they saw that potentially harmful medication errors occurred more often within pediatric care than in adult care. and then I thought I would just end to give you a sense of the incidence of ADRs. And these numbers are based on prospective studies, but it's a review, so they're all different. They have different settings, and so the span is quite wide. But about 11% of the inpatients of children experience ADRs, and much less in primary care and when they're admitted. So this background calls for action. Medicines need to develop for this population, and actually, especially in the US, I think they've been in the forefront in this work. They're working with the pharmaceutical industry and giving them actually an extended patent if they do trials on children, which in itself is difficult because there's lots of ethical questions around doing clinical trials in children. But I would say that monitoring for ADRs is very important, and the pharmacovigilance reports are incredibly valuable in this area, because if they're used, if they're sort of the use of medications are not fit within the normal regulatory realm, then the reports could contribute with valuable information. This is a study we did at the start, thinking about signal detection specifically in for the child data. So we wanted to make sort of an overall review of what does it look like in our database. So we did this study. With aims of we want to characterize the reports for children. So we extracted the data with ages 0 to 17. And we also want to see what type of adverse drug reactions have been reported to a higher extent during recent years, since we have reports from 1968 up to in this case 2010. We want to see what's being reported now and what should we focus on. And in that on that question, we divided the data into age groups. We saw that we excluded vaccine reports, I should say, because they're quite specific. So we want to look at non-vaccine reports. And we saw that there was a low proportion of reports for children in VigiBase, about 8%, 7.7%. We saw that there was we divided the data into different regions, and we saw that the regions Latin America, Africa, Asia, they had a higher proportion of reports than for North America, Oceania, and Europe. And any thoughts? Why do you think this is? I thought I would ask you now when I have you here. I think most of these continents are represented, isn't that right? Yes. Yeah.
The population of adults versus the children. Does it reflect, like for instance, the number of children in Africa versus the adults? Is it 15%?
Very good, yeah. Very good. That's it. 40% of that's what I've read, at least from 40% of the African population are children. Yeah, they're below 15 years old. So that's a very good point. But it actually doesn't relate to. It's very feasible to think that way for Africa, but Asia actually has about the same proportion as US. Yeah, it's all
it's the same profile. Younger population is more in Asia, especially in India. I don't know China.
Yeah,
and
it's
in Japan and China. I don't know, but in India, younger population is more than whatever is there in US or Europe.
Asia is a very wide group
Yeah,
of
but India,
countries.
India is the, I think after China, India has got the largest population, biggest population in the world, and the proportion of children will be much more
Yeah. Yeah.
if you see it
Higher.
in India.
Yeah. Yes. I don't know.
Yeah, for the question why so great proportion in these countries, perhaps it may hide a problem of a medication error. I think
Uh-huh.
so. Perhaps we have to explore and see prescription of drugs if there are not that there is not a differentiate between prescription in developed countries and developing country. The problem of medication error, I think, should be explored in that case.
Okay. It could also be access to the type of medication, maybe.
Yeah.
Yeah.
Yeah. Yeah. The type of
You
medication.
had a question.
That was my first concern, and
Yeah.
my second concern is, I don't think the population of these continents is that matters. I think the number of reports matters.
Yeah.
Maybe I expect more reports from, for example, from North America rather than Latin America, but the percentage is very high in Latin America. That might be the medication errors, the way the protocol they use.
Yeah. Okay.
So
So it's the use, you
yeah,
say more.
I think it is
Oh,
a
okay.
practice.
Interesting. Yes. We have someone.
I think in those continents it's a higher proportion of infectious diseases for
Yeah.
which children are treated than probably in Europe. So children are more medicated than in Europe.
Yeah. So, oh. Okay, thank you. Another finding, which is expected. Most reported reactions for children were skin reactions, and most reported drugs were anti-infective medicines. There are much more details about this study in the actual article, but I won't go into that. And this is a very busy slide. This is when we wanted to look at the more recently reported reactions by age group. So we looked at the proportions of reports for a recent time period and compared it to an earlier time period. And we saw that in this group, for the 1 month olds, many of the reactions were related to actually the in utero exposure of the baby. The other reactions were related to HIV medicines, and that's because they had actually an intensive monitoring. It was an intensive monitoring going on during this time period. So it's good to keep in mind. And for the 1 month to 2 years old, we saw that these are not dosing terms related to dosing problems and administrating problems that were common. Medication error we saw in all these groups. And the 2 to 11-year-olds, can anyone imagine or guess what drug all these are related to, except for that one? Yeah. Yeah? Yeah, the second time I've done this before, and as always someone, these are actually ADHD. All of these, we've had a bulk of those reports coming in during recent years. And this, the teenagers, suicidal ideation, suicide problems for the teenagers, reports. And this is probably affected by a high publicity around the antidepressants and teenagers and their potential susceptibility to this reaction. But that's also very sort of controversial, because this group of patients in general suicide is common, so it's difficult. So in VigiBase, we are now planning we will focus on, with the signal detection project, we are planning, based on this study and the background of the pediatric situation, we are planning to focus on serious skin reactions, because you saw that it was a very high proportion of reactions reported concerning the skin. But also we saw that Stevens-Johnson and toxic epidermal necrolysis were more common within the pediatric population than the adults, actually. The same applied to medication errors, were more common in the pediatric population than in the adult population. So that's why we wanted to focus on those areas, and also the psychotropic medicines in general. So the older children commonly use medicines, but they're not always at all labeled for teenagers. It's actually a lack of medicines for teenagers with psychiatric problems that often occur during these ages. Then we want to go deeper into how to do with geographical regions with a higher proportion of child reports. We saw that congenital birth defects often lacked age, for example, so they were not captured at all in our study. They lacked age, or they had age on the mother, which is so in VigiFlow, for example, you can enter both the age for the mother and for the baby. So the reporting of parent-child is much better now than it used to be, and I mean we studied all years. So and if you don't use this newer format, it's important to, in this case, to record the age of the mother in the narrative, for example, just so that both are there. Prematurity was another sort of aspect. You can't determine that from the age field. For example, if you say 1 day, the child is 1 day, okay, but it might be premature, it might not be premature. It's 1 day, so that's a problem, and so it's very important to record the weight for that child, because you can get guided that you can think that a baby is premature by the weight. It doesn't have to be the case. So the narrative is especially important in this to capture this information. And also I would like to stress that strength, route of administration and dosage form is very important when it comes to the reporting for children, because of the difficulties in dosing and administration for children. We also saw, I mean, you know that vaccine reports are very commonly reported naturally for children. So we decided to actually have separate signal detection groups. And it was difficult to just by the age field to differentiate problems related to in utero exposure to, for example, via breast milk, or newborns' own drug intake. That was difficult when we looked at the 1 month old. You have to look at, then you have to relate the reaction to the drug. And this slide relates to the quantitative evaluation of child reports. Of course, when you see a report, you can determine this, but quantitatively it was difficult. I think I will. 4% the signal. We did a retrospective review and saw that only 4% of our signals at the UMC related to the child population. And our current routine at the UMC focuses on new drugs and not labeled reactions, but old drugs are often used for children. And also, just because it's labeled for and known for adults, it might not be known for children. So that's why we want to continue. That's why we're planning for signal detection in data for children, and we are hoping to start. We are in the process of actually doing it now, and we want to contribute with further knowledge for rare and serious reactions, because that's where we see that Vigibase is particularly useful. And we also want to detect unexpected and unrecognized reactions within each age group. So just for you to remember to take home, safety medicine can be considered safe, but it doesn't have to be safe for a child. And it's also important to think that always consider the use and practice of giving medication to children when you sit with or when you evaluate reports or data for children. Yeah. Thank you.